This is a discussion about non-alcoholic fatty liver disease, which is now called metabolic dysfunction-associated steatotic liver disease. The top liver disorders that are seen in a primary care office are viral hepatitis, including A, B, and C, MASLD, which is metabolic dysfunction-associated steatotic liver disease, which was formerly known as non-alcoholic fatty liver disease, hyperlipidemia, which includes elevated cholesterol, LDL, and triglycerides. The liver is the largest solid organ in the body. It performs both endocrine and exocrine functions. Endocrine means that it secretes hormones directly into the bloodstream, while exocrine means that it secretes substance into ducts that then excrete them into the body or onto body surfaces. The liver is located in the right upper quadrant of the abdomen, safely tucked under the ribs. It's divided into two lobes, the right and the left. Each of these lobes has 8 segments made of thousands of functional units called lobules. The lobules are connected to the portal vein and the hepatic artery via capillary-like tubes called sinusoids. These sinusoids carry the hepatocytes, which are the main type of liver cell, and they make up 80% of the liver mass. Hepatocytes perform most of the liver's functions. The liver is a very vascular organ. At any time, it holds up to 13% of the blood supply. In addition to getting oxygenated blood from the heart, the liver gets blood from the portal vein. Nutrients, drugs, alcohol, etc. are absorbed from the GI tract, the stomach, the intestines, the colon, and the rectum, directly into the portal vein, which then goes directly to the liver for what we call a first pass metabolism. Remember that most drugs that we prescribe are metabolized by the liver. Within the liver are the hepatic ducts. There's the right and the left, which combine to form a common hepatic duct, which carries bile into the gallbladder. The common duct then joins the cystic duct from the pancreas to form the common bile duct. The common bile duct actually passes through the pancreas before it empties bile and digestive enzymes into the duodenum, or the first part of the small intestine. Bile is made of cholesterol, bile salts, and bilirubin, and is part of the fat metabolism. In addition to making bile, the liver also makes proteins for blood plasma. The main protein is albumin, which helps us maintain oncotic pressure in the blood vessels. That helps us maintain blood pressure. It also makes immune factors, immunoglobulins, clotting factors, and converts glucose to glycogen. It regulates amino acid formation and breaks down red blood cells into the components of iron. It also clears bilirubin from the blood. Metabolic dysfunction-associated steatotic liver disease is the most common cause of elevated liver function studies, primarily ALT and AST. The name was changed from non-alcoholic fatty liver disease to MASLD in 2023, and this was because of the stigma that was related to cirrhosis and alcohol, and also to encompass the full extent of the biology of the disease, specifically metabolic dysfunction and steatosis, which is fatty liver. So what is metabolic dysfunction-associated steatotic liver disease? Well, it is steatosis, or fat accumulation in the liver, plus any dysmetabolism that includes obesity, hyperglycemia, hypertension, hypertriglyceridemia, and/or low HDL. And that includes being treated for diabetes, being treated for hypertension, or being treated for elevated cholesterol. And this is in the absence of other causes of steatosis or fatty liver, which could be viral hepatitis or alcohol overuse or some other type of disease process. Those people who are most at risk for developing MASLD are people that have prediabetes, diabetes, hypertension, obesity, or dyslipidemia. So think metabolic syndrome. MASLD can progress from steatosis, fat deposits in the liver, to inflammation of the liver, which is called steatohepatitis, to fibrosis, which is severe scarring of the liver from inflammation, all the way to cirrhosis, which is the loss of functioning hepatocytes because of the replacement of those with scar tissue. MASLD is generally asymptomatic early on. It's often found incidentally on abdominal ultrasound or by elevations in ALT and AST. To work up MASLD, the primary care provider needs to have a high index of suspicion for patients who are obese or have prediabetes, metabolic syndrome, or any patient with evidence of steatosis on abdominal ultrasound, regardless of their liver function studies. The physical exam is often unremarkable. There may be obesity. There may be signs of undiagnosed diabetes, such as polydipsia, polyphagia, or acanthosis. There can be liver enlargement, but that's usually not present early in steatosis. Symptoms change with the progression of the disease. Patients with increased risk of liver fibrosis can actually be screened using the FIB-4 method. This uses age, the AST, platelets, and ALT to calculate a score related to risk. Patients with diabetes may already have stages 2 or 3, which don't necessarily correlate with fibrosis, but that's for another lecture at another time. This is the criteria that is used for diagnosing adults and children with metabolic dysfunction. We see a lot of pediatrics with metabolic dysfunction because of obesity. We also see them with fatty liver disease. Notice the BMI, the fasting serum glucose, the parameters for blood pressure, triglycerides, and cholesterol. Also notice that with hypertension and the hyperlipidemia, the use of an antihypertensive drug or lipid-lowering agent counts as positive for this criteria. Liver function tests include the ALT, the AST, alkaline phos, GGT, LDH, albumin, and bilirubin. For fatty liver disease, we will look at the ALT and the AST. These are enzymes that are released by hepatocytes when they're damaged. Dysmetabolism damages the body over time. It's a chronic disease. ALT, think L for liver, is specific to the liver, while the AST is more nonspecific and can be found in other organs. The upper limit of normal for ALT and AST is about 35 to 40 international units per liter, or IUs per liter. So what kind of elevation are we talking about? In fatty liver disease, ALT and AST are usually elevated less than 500 IUs per liter. Elevations greater than 1,000 typically point to acute processes. Remember that fatty liver disease is chronic. ALT elevation is predominant in fatty liver disease. For instance, you may see an ALT of 58, which is elevated, and an AST of 34, which is not elevated. This points me in the direction of fatty liver disease, especially in patients with obesity, metabolic syndrome, diabetes, and so forth. A clinical pearl for you is that the AST is often elevated in alcoholic liver disease. It may be 2 times the ALT. For instance, an AST of 300 and an ALT of 150 leads me to think of liver disease, but related to alcohol rather than to dysmetabolic syndrome. The management of fatty liver disease used to be confined to weight management, diabetes, and so forth, but now we take a little more active approach, not just weight management and diabetes, but we're also managing hypertension, atherogenic dyslipidemia, that's cholesterol, LDL. We will also refer to the right specialist for co-management. If someone has persistently elevated ALT or AST or signs of hepatic steatosis seen on imaging, or they're high risk based on blood tests, we may want to send them to a hepatologist or someone who can give us a hand. In a primary care clinic, we're going to try to manage this with the things that are listed here: weight management, maximizing diabetes control to get them to a target A1C, getting the hypertension under control, and managing their cholesterol. If we are having difficulties with this, or if there is persistent elevation, this is when we are going to send them to a specialist. Let's look at a case study of a 56-year-old male who is seen in your primary care clinic for a 6-month follow-up and some labs. He has no complaints today. He's feeling good. So the history of the present illness is that he's here for a 6-month follow-up and he's feeling good. His past medical history is unremarkable. That means there's nothing you need to follow up on today. His family history is significant for a maternal grandmother who had obesity and type 2 diabetes. He takes no medications at this time, and his social history is significant for 20-pack year smoker. He does not take in alcohol, and he plays tennis twice a week. So what I want you to start thinking about here is, what is this profile for risk? Remember that as we age, our risk for cardiovascular disease increases. For his physical exam, his blood pressure is within target. His pulse is regular at 78, his respirations are 16, and his BMI is 32. That's significant. Physical exam, he's well-developed, well-nourished, obese male in no distress. He's normocephalic. His pupils are equal, round, and reactive to light. His extraocular movements are intact. Oral mucosa is pink and moist. Trachea is midline. There is no thyromegaly. His heart is regular rate and rhythm. S1 and S2 are distinct. His respirations are unlabored and his lungs are clear to auscultation. His abdomen is obese. His waist circumference is 43 inches. He has normal active bowel sounds in 4 quadrants, no tenderness or rebound tenderness on palpation, and no hepatosplenomegaly. His peripheral pulses are 2+. He has capillary refill is brisk, and he has no lower extremity edema. For musculoskeletal, he moves all his extremities well. So this is an unremarkable physical exam, except for the fact that he is obese, his BMI is elevated, and his waist circumference is over the 37 inches that is recommended. So let's start an assessment. That means that you start looking at differentials that are based on your history and your physical. And we went ahead and got some labs. So let's just look at the labs first. CBC was within normal limits. His chemistry was within normal limits, except his total cholesterol was 250. His LDL was elevated at 160. His HDL was lower than 40 at 38. And his triglycerides were elevated above 150 to 190. What do you think is going on here? Keep in mind the criteria for metabolic syndrome. Does he have metabolic syndrome? Well, according to the criteria, you need 3 of the 5 indicators, and obesity is one of them. So let's look at some of the other differentials. Let's just keep that other metabolic in the back of our mind for a minute. If he has metabolic syndrome, is he at risk for fatty liver disease? Yes. And do you think he could have or be developing fatty liver disease? Maybe I don't have enough information just yet. Let's move on. Let's look at this table for diagnostic criteria for metabolic syndrome. 3 of 5 are needed. Now, he has 3 of these 5. Abdominal obesity. His waist circumference on this particular slide is greater than 40 inches at 43 inches. Hypertriglyceridemia, yes, his is 190. This is above the 150. Low HDL-C, his is less than 40 at 38. His blood pressure is normal and his fasting glucose is normal. He has metabolic syndrome. Okay, does he have fatty liver disease or MASLD? And what we need there is evidence of steatosis or fat in the liver. Now, there is a little bit of evidence that it could be there because his ALT is elevated, but we don't have enough information at this point to point to fatty liver. He does have dysmetabolism, or if you think of metabolic syndrome as dysmetabolism, he has 3 of the 5 indicators. Does he have viral hepatitis? We don't know. We need to check for that. And he does not use alcohol. Okay. So what's your final diagnosis in your plan? Well, you don't have enough information to diagnose this person with fatty liver disease right now, but it is a differential. He has 3 of the 5 criteria for metabolic syndrome, so he has metabolic syndrome. Is he pre-diabetic? Not yet. His fasting blood sugar is 91. Is he at risk for developing diabetes? Yes. He has a family history, and he is obese. Another differential diagnosis is elevated liver enzymes. We can't say he has fatty liver disease, but we can say that his liver enzymes are elevated as a differential. Now, they're not greatly elevated at this time. His lipids are elevated, so there's another differential diagnosis. So final differentials or final diagnoses include obesity, elevated liver enzymes, and dyslipidemia. That together, in my mind, makes me think that he is headed for diabetes and fatty liver disease. So what's my plan? I would repeat the ALT and the AST in 3 months. And I'd also check for hepatitis B and hepatitis C, or viruses, just to see. He's of an age where he could be at risk for hepatitis C. Now, do I want to refer him to a specialist today? No. This is not good for business if I refer everybody with an elevated liver enzyme. Let me look at this. First of all, when I think about it, his liver enzymes are only elevated a little bit above the upper limits of normal. We have some time here. And we can wait 3 months and recheck them. If they continue to elevate, that may be an indication. But how are we going to treat this guy? What are we going to do about his obesity? Well, certainly we can do diet, exercise, or what we call lifestyle changes. He may be a really good candidate to send to a nutritionist for some help. Sending somebody home with a prescription to just start to lose weight is not going to be very helpful. They're going to need some information, especially about nutrition, reading labels, etc. And a nutritionist can help with that. What about treating his dyslipidemia? Would you put him on a statin? Well, think about it. His triglycerides are 190, and his HDL is 38, and his LDL is 160. He really does need to be on a statin at this point. We need to go ahead and treat him for dyslipidemia. or you may see it also as hyperlipidemia. What dosage do you want to put him on? Well, today let's check out atorvastatin and rosuvastatin. Those are two of the most commonly prescribed statins. They tend to be medium to bigger strength in intensity, and so work up some dosages. What would you diagnose or give this patient diagnosed with dyslipidemia? Your choice, atorvastatin or rosuvastatin, but come up with a dosage.